This afternoon, Dr. DiRocco will be speaking about fecal incontinence and the common symptoms patients experience, as well as the treatment options that may help you to regain bowel control. So just a little bit of important information. These slides contain important safety information about the products you're about to learn about. As with all medical procedures, there are some risks, so please visit the Axonics website for more information, and remember to bring all those important questions to your appointment with your physician. This afternoon, Dr. DiRocco will be speaking about fecal incontinence and the common symptoms. He is a board-certified physician in surgery, as well as colon and rectal surgery, and has been named the Director of Gastrointestinal Oncology for Sandra and Malcolm Berman Cancer Center Institute at GBMC. Without further ado, I introduce Dr. DiRocco.
So we're going to talk about bowel incontinence or accidental bowel leakage. The bowel symptoms, if you have no control over when or where you're going to the bathroom, it can be massively disruptive to your entire social life and often leads people to be homebound or terrified to go out or have to make adjustments. Common complaints are that I constantly have to stop on trips. I missed the best part of the show, or oftentimes I didn't even bother considering going to the show. I need a bathroom nearby. I worry I won't make it. A lot of patients with accidental bowel leakage or trouble controlling their stools often forgo social events. They stay away from family members. They're afraid to go shopping. There's can be massively disruptive in people's lives. But, if you do experience any of these symptoms, you should know that you are not alone. In fact, there are 19 million adults that suffer from bowel incontinence in the United States. And how many of these people actually come to try and get help? Only a very small fraction. Why is that? Mostly because people don't know that there is help, what kind of help is available, and they're already terribly embarrassed of their condition to start with. They don't talk to other people about it. They don't talk to their doctor about it. And as a result, it can be quite isolated. So it's important to understand your condition and the nature of where it comes from and what kind of treatment options are available. Going over normal bowel function, you can see the illustration on the screen shows colon and small intestines, including the rectum and anus. And so when we swallow liquids or food, it travels through our intestines and all the nutrients are absorbed in the small intestine. Finally, a liquid dumps out of the small intestine into the colon, and the colon's only job in your life is to suck water out of the stools so you can get formed stools. Your rectum allows things to stretch up so you have some time before you have to go to the bathroom. And then there are nerves sent down from your brain to make you feel like you need to move your bowels once that rectum is stretched out and your colon says, well, we got something ready to happen. And then nerves coordinate with your pelvic floor to relax the muscles. And with a little pushing, the stool comes out where and when you want. But unfortunately, for many people, this process doesn't work well. And as a result, they can have bowel movements or urgency at a time and location that is very inconvenient, to say the least. So what is bowel incontinence? Fecal incontinence is the uncontrolled loss of stool, whether it's mucus, liquid, or solid waste. The symptoms can include urge incontinence, passive incontinence, and soiling. And so what do those mean? If we look at fecal urgency, that's where a sudden urge to pass stool. And a lot of patients, even if they don't have overt bowel incontinence, where they don't actually not make it to the bathroom, that urgency itself can be very disruptive to their lives, because all of a sudden you can be doing whatever you're doing and suddenly you have to interrupt your activities and run and find a bathroom. Sometimes that urgency is not accompanied by the ability to make it to the bathroom in time. And so you have all this urgency, you try to make it to the bathroom, but then, you don't make it in time. And so as a result, you can pass stool, and some people need to wear diapers or pads or protective undergarments, and some people don't even have any real warning that this is going to happen and can be sporadic, and as a result, they can be unprepared. Passive fecal incontinence is a different pattern of bowel incontinence, and that can be the passage of stool, which can be with liquids or solid waste, regardless. And this can happen with no warning whatsoever. So there's no awareness. Suddenly they feel either a moisture or start smelling things, or somebody around them notices things. And as you can imagine, or as you've experienced, it could be very distressing. So we sort of went over a little bit on how this affects people's lives. It limits participation in physical activities. There are reduced social interactions, altered travel plans. Like, some people don't want to travel for any considerable distance because they need to know that they're very close to a bathroom. Um, the psychological effects of having this, including, like, an embarrassment or loss of self-respect, this constant fear of having accidents, and then some associated guilt or depression, like, something that they're doing or something that they can't escape. And, a sense of hopelessness can be attached with this, where people attribute this just to, aging or inevitability. But as we'll talk about, there are things that we can do to help out with this. Um, as you can imagine, avoiding sexual contact and intimacy. We've had patients that have not had any relations with their spouse or partner because they're afraid that any kind of activity down there is going to result in, accidental loss of stool and cause significant embarrassment, and they don't want to take a chance. Um, Occupational things, absence from work. If your job requires you to be, at some distance from a bathroom, then you may not be able to continue working in that situation, or you might have decreased productivity because you're constantly going back and forth to the bathroom to either check or clean up, and you have to bring some patients bring a whole bag, or have an emergency bag with change of clothes and additional pads, etc. Also, the very nature of having to wear pads or diapers or having to use special bedding, not only is this very uncomfortable and embarrassing, but, can be quite costly over time. And a lot of people have ruined a number of sets of clothes as a result of this. But bowel incontinence is not a normal part of getting older, although as you get older, it does become more likely, and it is almost never caused by something you did. Um, the can be a natural consequence, or just the way you're wired, where things don't work very well, or it could be a result of, you know, one of the people that you love most in life, either by your children through childbirth, or, your colorectal surgeon through some result of surgery. But most of the time, there's no real reason why this happens, but there is like a whole algorithm that we'll talk about, where we go through and work up the condition and find the best treatment for you. So, as I mentioned, there are treatments to help you regain control of your bowel, and let's talk about that now. Um, this starts with coming to see myself or somebody else who treats bowel incontinence. Um, Oftentimes people will start discussing it with their primary care or their gynecologist or their gastroenterologist, everybody can sort of help you on the path, but in terms of bowel incontinence, as a colorectal surgeon, this is like the area where we're specialists and have the most training and experience and treatment options. So uh, if you don't know a colorectal surgeon, I would ask your primary care physician to refer you to somebody that can help get you on this pathway towards improving your quality of life. What happens once you come in? The first thing we do when I meet somebody is we go through your symptoms in terms of how often you have bowel leakage, what the conditions are in which they happen, whether or not you have any awareness or urgency. Um, Basically, get a snapshot of what type of pattern of bowel incontinence you're experiencing. At that point, if you haven't already started to do it, we give you materials to start a daily diary of your episodes of bowel incontinence, and we can sort of match that up with different factors to see where we can help. Um, Sometimes at the initial visit, but oftentimes at a follow-up, we do additional testing. And that additional testing I'll talk about later, but it's basically tests that measure the function of the anus and rectum. If you haven't had a colonoscopy, oftentimes we recommend that to see if there's some underlying problem with the colon. Um, a lot of the time, but certainly not all the time, patients come in with this issue, and it typically happens only when they're having loose or watery stools. So, uh, appropriate diagnosis and management of diarrhea or problems with stool consistency uh, is really the first step in this process. Um, that can be addressed through dietary modification and additional testing, like I mentioned, a colonoscopy, maybe stool studies, maybe um, additional blood work to try and understand why somebody's having these um, problems with maintaining like formed stools. But that oftentimes is the initial workup, is trying to get the best stool possible for your body to manage. Um, and once we figure out, all right, this is, we've gotten the best stool possible and this problem is still occurring. We've done the testing on the anus to see how strong and what the reflexes and nerve function is of the anal area. Then we can start trying some basic things. Those basic things include dietary changes. So most, but not all the time, we recommend an increase in dietary fiber through diet alone or through the use of supplements like things like Metamucil or Citracel, other products that basically bulk up the stool so that your body can know when it's coming and push it along more completely and easily. Sometimes that alone is not sufficient, and we have to slow things down a little bit. So the use of antidiarrheal medications is also a critical initial step. Just slowing the bowel down enough so that patients have more warning and less urgency oftentimes can be life-changing. So those are the initial things. If there's some um, disruption to the anatomy in the pelvis. Oftentimes, uh, especially if patients have urinary symptoms, we would have them see a urogynecologist or urologist that specializes in overactive bladder or urinary leakage, and they may recommend a pessary or other interventions to deal with that part of it. From the colorectal perspective, um, oftentimes I personally wouldn't recommend a pessary to somebody. It's not my area of expertise. So, but in terms of antidiarrheal medications, there are a variety of different approaches, and sort of it depends on your symptoms and the type of diarrhea that you're having. For some patients, they've just had, they're missing a gallbladder, and so they have diarrhea as a result of that. The medications prescribed are different than what it would do for just somebody else. And sometimes people have inflammatory conditions that causes diarrhea. We have to give anti-inflammatory medicines specifically designed to help improve bowel function. So we do all these things, and honestly, the majority of patients are improved with just these simple interventions and recommendations. But what happens when they don't help? And so at that initial test, we have patients come back and after doing these interventions, and we can see, do we just need to tweak the medications? Do we need to try something different? Does a patient have, some real problems where they may benefit from pelvic floor physical therapy? We can send patients to pelvic floor physical therapists and see how that improves things. But even when all of the best advice and medications and things that we come up with are insufficient in terms of controlling the bowel leakage, well, there's more help. And so this is the part that patients really know very little to anything about. And honestly, most other physicians who don't have experience in this field may not have a lot of experience or knowledge about these things. And so that's why, again, it's important to follow up with specialists. So what are these advanced therapies? We'll touch on them individually in a moment, but those are sacral neuromodulation, which is going to be the main focus today, but also transanal irrigation and sphincter repair. And what's not listed on here is the thing that patients probably are afraid I'm going to recommend, and most have zero interest in having, which is to have some sort of colostomy or a bag. That's just trading incontinence in your pants for incontinence in a bag. There are some patients where that is really the best possible option for them, but that's very unusual and only in like very specific circumstances. So if the concern is that you don't want to go and see somebody because they're just going to recommend having a bag, or that's the only thing that we could offer. And once upon a time, that was true, 20, 30 years ago, apart from doing a sphincter repair, the only other option was to have a bag. But that is almost never done for this condition. So what are the initial things? I sort of already went over some of these initial treatment regimens, so I won't linger on this, but pelvic floor physical therapy, and here at GBMC, we have our own pelvic floor physical therapist who's wonderful. We can refer you to her or outside if geographically it's not convenient. In terms of dietary changes, again, most of the things are figuring out what foods trigger loose stools, avoiding them, changing the diet, and adding bulking agents like fiber or other bulk forming agents. Antidiarrheal medications, I think I've talked about enough, and a pessary, again, would be recommended by somebody such as a urogynecologist. So transanal irrigation. This is something which is basically a fancy enema. For some people, they have no awareness that stool's that they can pass stool, or they can be backed up and then urgency strikes. And while nobody relishes the idea of administering an enema, because nobody even likes to mess around with their backside, it can be very helpful for a lot of people. Basically, what an enema does is it flushes out the very last part of the colon and rectum. And if you can manage it, which a lot of people may not be able to self-administer an enema just because logistically they don't have like the hand sort of flexibility or coordination to be able to do it, or the enema itself just doesn't stay in. But for some people where they're able to administer an enema to themselves, it can basically flush out the lower portion of the colon, and basically by doing that, you've bought yourself some time. And what it does is it allows you to eliminate more fully than you would ordinarily by going to the bathroom. And so once you're empty, at least the last part, you have some time until things work their way down there again. There are fancier transanal irrigation systems that involve like actual enema bags and use of a balloon to try and retain as much of the fluid as possible so you get a more complete flush. But these devices are cost prohibitive and not covered by insurance, and so it remains a good option for very few patients. There's also a concept of doing colon hydrotherapy, which is a more complete flush, but that again is can be cost prohibitive, and you know, it's unclear how often you would need to do it in order to remain symptom free. So that's not often a recommendation. Sphincter repair, sphincteroplasty, which is the name of the procedure, which is done. You can see in the illustration, we're basically taking a circular muscle, which is the anal sphincter, and repairing it. And so what happens, this is often what happens during childbirth injuries, especially women who've had an episiotomy or a more severe tear through the perineal body. Even though it may initially be sutured up by the obstetrician, sometimes that tear can either be unrecognized or weaken and stretch out over time. We do ultrasounds to take a look at the muscle to assess how badly things are split open. Also, a good digital rectal exam can help characterize how poorly the muscle is together. But for some patients, tightening up the muscle, especially in situations where there's gross deformity or the area in between the anus and vagina is, almost one wide open circle. Doing a muscle repair can be very helpful. The problem with these muscle repairs are that typically when we do them, we are able to sew some of the scar together, but the muscle itself is not a very strong tissue that can hold stitches. And the results of doing a sphincter repair are not that great over time for patients who are just doing it for incontinence, meaning that, it's a judgment call in terms of how tight we make the muscle during surgery. So sometimes things can be so tight that it can be hard to pass stool and patients can have fairly severe constipation. Other times it's still too loose and it doesn't tighten things up enough to make a substantial improvement in patients' quality of life. And then even when everything goes well, over time, that area of the repair can weaken and almost half of people are back to where they started by 5 years. Now, I'm making this sound terrible. And for some patients, it's actually like the absolute best thing that we can do for them, again, in particular situations. So I'm not saying that this is not the right option for anybody, but it's not the right option for everybody. Anyway, what is a sphincteroplasty like? What is your experience if you're a patient having this done? Most of the time, it's an outpatient procedure. Sometimes patients stay overnight. You come in, you go under anesthesia. While you're asleep, we make an incision in the area in between the anus and vagina and basically find this muscle, tighten everything up. Sometimes we do things in layers and typically have a bladder catheter that stays in for a few days. And again, most of the incisions down in that area are right on the bicycle seat area. There are problems that can occur with surgery, such as infection or problems with emptying the bladder afterwards, but that's why we use a catheter and we monitor things. But most of the time, patients do well. So that's the sphincteroplasty. Now, the main treatment that we're using in the last, I've been doing this for over 10 years. It's been FDA approved for almost 13, is sacral neuromodulation therapy. And so sacral neuromodulation therapy modulates the activity of the sacral nerve. Sacral nerves are down in the pelvis, below where the spinal cord ends. And by modulating or stimulating those nerves, it can help restore bowel control. Well, how do we know if it's going to work? We do a trial on all patients before we actually go ahead and use this long-term solution just to make sure that it's going to be helpful. And this trial can be done either in the office or in an operating room. It can be done without anesthesia or with anesthesia. I typically do these with sedation just so it's more comfortable for everybody, and almost everybody enjoys going to sleep for a few minutes and getting a nice nap. You don't have to do a bowel prep like you do for a colonoscopy. You just have to show up with an empty stomach. If we do it in the office, basically this trial involves numbing up an area on the lower back and having a little needle stick. That needle is smaller than what you would get for an IV. So it's usually not pretty well tolerated. The concept of nerve stimulation and having these procedures with, possible implantation gets some patients very anxious. This is honestly safer than a colonoscopy. So most patients with this problem have had a colonoscopy at some point in their lives. This is like by far a safer procedure. This is not something that you need to be worried about. Still, it can be alarming just having this concept and people not knowing what it's about. So that's what this webinar hopefully will help you with in terms of getting more information, so it's less scary and you can be more optimistic about coming in for potential sacral neuromodulation therapy. I am not being paid for this, but I am a strong believer and feel like there are a number of patients out there who either have no knowledge or fear of seeking help for this. And so that's why I'm doing it. So I mentioned the trial. After a successful trial, then you would go and get a small discrete implant, which goes down in the buttocks. There's nothing that you can see visibly when you're walking around. Like this is Jill and Melissa. I don't know them, but apparently they're real axonics therapy patients. They seem very happy and they have no visible scars or implants on their body. At least not visible in this picture. All right. What is axonics therapy? Well, it's therapy that helps not just with bowel incontinence, which is my area of expertise, but also with bladder disorders. And originally, this technique was developed for patients with overactive bladder and urinary retention. And what they found out is that those patients who also had bowel incontinence had even better results. And so as a result, they subsequently got improved for what I treat, and it has been a game changer, not just for me, but for my entire specialty. How does this work? Well, the idea is that for many patients, overactive bladder, bowel incontinence, and urinary retention can be caused by abnormal communication between the brain and the bowel, or the brain and the bladder. Basically, the bowel and the bladder are all supplied by nerves down in the pelvis, and those are sacral nerves. So axonics therapy provides gentle stimulation to those nerves that control the bladder and bowel. And what does that mean by gentle stimulation? It does not mean that you're going to be experiencing a constant state of being shocked or even aware of the stimulation. When we initially set the programming or make adjustments, sometimes patients can feel a little bit in the area, but usually the brain tunes that out after a very short period of time. But the stimulation can help restore normal communication between the brain and the bowel, which ultimately results in improvement in symptoms. So if you determine that, and we determine that axonics therapy is right, then we do this test to see if you have a satisfactory reduction in symptoms. Again, as I mentioned before, the initial test is a minimally invasive trial that can be done in the office or surgery center. Um, there are two tests that we do. One is called a peripheral nerve evaluation, which usually we only test for about a week or so, because it's a very thin wire, like almost the size of like angel hair pasta, maybe even skinnier, like thin. And that wire is threaded with a needle down around the nerves, and then you have a sticker and some battery that goes around your waist, and that way we can test things out. Because it's not anchored in any way, shape, or form, and if you decided, like, I need, I'm going to the Oscars tonight, I don't want to wear this device, I'm going to take it off. I mean, literally, you could take the dressing off and the wire would come out and you wouldn't even have felt it. It's so skinny. Once that wire's in and we do this test for, a few days to a week or so, if you have improvement, then we can go on and place the device. When we place the device, then we have to do things in a hospital setting or in a surgery center where we have ability to use x-rays and sterile technique to make sure that the device is placed in the appropriate location with the best long-term outcome. Sometimes patients, we need to do a longer treatment, a longer test to make sure, or there are some other factors where we really need like a more secure test to make absolutely sure that this is going to be helpful. Then we would do those again in a surgery center or in the hospital. The leads or the wires there would be the same as what you would have permanently, but they're placed under x-ray, under sterile conditions. And if that test works out well, then doing the implant is a very simple process of just reconnecting the wires. Both of those things would be in a hospital or surgery center again, and those are usually scheduled about 2 weeks after the initial trial placement. During that trial, you're going to continue with this bowel or bladder diary in terms of how often you have episodes, how often you have urgency, and we can see, because we typically test one or both sides, you want to see maybe the left side worked well, the right side not so well, or vice versa, or maybe you didn't even need to switch sides because, the initial trial showed that basically your problem went away and let's do it. What are the options in terms of the actual implant? And how often do people who have a trial end up with an implant? Like the percentage is very high. I mean, well over 80%, maybe even higher than that. Most people who have a trial do experience significant improvement. And so the question is going to be, well, all right, if I'm going to have an implant, which one would I want to have? Historically, there's only been a device that has a battery contained in the device that can only last for so long. Initial ones lasted 5 years or less, sometimes 7, but patients would have to come in and have these things replaced periodically. Axonics has been in the forefront of developing rechargeable batteries and batteries that last much longer. The battery that can recharge, that's pictured on the left. It's hard to get a sense of how big or actually how small this is based on the picture, but this thing is tiny. We make a little incision that's like maybe like an inch long, and slip this device in through that incision. It goes under the skin in the buttocks, and you can barely feel it, let alone see where it is. Um, Even if you were wearing a bathing suit or something, I doubt you would even be able to tell where this is. The rechargeable device does have to get recharged by definition, and you can see the picture on the left. There's like a white disc. That's sort of like wireless charging for your cell phone or Apple Watch or whatever you use. You just wear a belt around the area for a brief period of time, and how often you have to charge depends partially on how much energy the device needs to provide the good results that you're looking for. So we try very hard in the operating room to make sure we have it really in the best location possible that requires the minimal amount of energy. So that way these batteries can last for, over 6 months in between charges. That's the goal. And then if you really don't want to bother with anything that needs to be recharged, there's a more permanent battery device that lasts for somewhere between 10 and 20 years. And they keep pushing the envelope in terms of how long these things last. But the idea of the non-rechargeable or recharge-free device is that, it's just put in and you don't even have to really think about it. You can see that key fob that looks like a garage door opener. They've really simplified the design of this device. That's the control for the unit. And basically you can use those arrows to make adjustments, but most of the time people don't need to even mess with that thing, except when they bring it in for visits or if they have questions or concerns. The remote control, as it's called, it literally looks like a garage door opener there. The original ones involved like complicated cell phone devices with Bluetooth connections, and patients had a lot of difficulty understanding how to use it, and many patients would forget to even bring them in. When they would see people, the batteries would be dead, but this is a much easier device to use. One major limitation where patients either want to have their old devices removed or are very hesitant to have any kind of implant is, you're putting a device in your body. MRIs use very powerful magnets to obtain imaging. And the question is, well, can you get an MRI with this device? The original devices, the answer was no. And so a number of people had bad problems that required MRIs. They would sacrifice their bowel control just to be able to get this type of imaging. But now people don't need to make that sacrifice or make that choice. The newer devices are approved for most MRIs. I'm not sure if I've conveyed like how successful this is. I told you that like most patients who have a trial end up getting the implant. And even by 2 years, you can see this data, 93% of patients still have significant improvements in their bowel control. That doesn't mean that 93% of patients don't have any issues, but significant improvements. And there are a large number of patients who have no further issues as well. Compare this to when I talked about the sphincter repair, where, as time goes on, the quality of the sphincter repair degrades. With this intervention, this nerve stimulation will continue to work for as long as the device is able to stimulate those nerves. So much greater duration, and the ease of the procedure and the recovery, which is basically non-existent, makes this a terrific option. So as I mentioned there, 93% of patients have ongoing symptomatic improvement. Most are satisfied. Most would do the same thing again with the same results. So high level of satisfaction. There's very little buyer's remorse where they go through all this stuff and then they're like, why did I bother doing this? So I hope that gives you confidence to consider at least getting evaluated for bowel incontinence. And if we end up getting there, undergoing sacral neuromodulation. So with that, I'll conclude like the lecture part of my talk. Thank you.
Thank you, Dr. DiRocco. It was a pleasure hearing from you and your experience with treating patients suffering from fecal incontinence. If you'd like more information or you'd like to schedule an appointment, please call Dr. DiRocco's office. Thank you so much.